Co-1. What is asthma? A1. Asthma, also called reactive airway disease, is a condition where the airways become abnormally narrow due to bronchoconstriction. Q2. How is asthma different from chronic obstructive pulmonary disease, COPD? A2. Asthma is a reversible obstructive lung disease, meaning the airway narrowing can be treated to return to normal. COPD, however, causes irreversible damage to the lungs. Q3. Is asthma becoming more common? A3. Yes. Asthma prevalence, how common it is, incidence, new cases, and hospitalization rates are all increasing. Q4. Do we know the exact cause of asthma? A4. No, the exact cause is unknown, but it is associated with atopic disorders, allergy-related conditions, and obesity. Q5. What triggers acute asthma symptoms? A5. Common triggers include allergens, infections and environmental factors, lifestyle factors, menstrual cycle, medications or substances, and medical conditions. Q6. What are the key symptoms of asthma? A6. Wheezing, acute shortness of breath, cough, and chest tightness. Q7. Is sputum production common in asthma? A7. Yes, increased sputum, mucus, is common, but fever is not always present. Q8. Are asthma symptoms worse at a specific time? A8. Yes, symptoms are typically worse at night. Q9. What physical signs might be associated with asthma? A9. Nasal polyps and sensitivity to aspirin, eczema or atopic dermatitis on the skin, a longer expiration phase, and use of accessory respiratory muscles. Q10. What is the best initial test during an acute asthma attack? A10. The peak expiratory flow, PEF, or arterial blood gas, ABG test. These assess lung function and oxygen levels during an attack. Q11. What does a chest X-ray show in asthma? A11. It is usually normal but may show hyperinflation, air trapped in the lungs. A chest X-ray is also used to rule out other conditions, such as pneumonia, pneumothorax, and congestive heart failure. Q12. What is the most accurate diagnostic test for asthma? A12. Pulmonary function testing, PFTs, is the most accurate test. Q13. What does spirometry reveal in asthma? A13. It shows a decrease in the FEV1-FVC ratio, the amount of air exhaled in 1 second compared to the total air exhaled. Q14. What happens if the patient is asymptomatic during testing? A14. The test may falsely appear normal, negative. A special test can be done using methacholine or histamine to confirm asthma. Q15. Are there situations where asthma presents only as a cough? A15. Yes, asthma can sometimes appear exclusively as a chronic cough without other obvious symptoms. QE16. What is the role of flow volume loops in asthma diagnosis? A16. Flow volume loops are not typically used for asthma, but are better for identifying fixed airway obstructions, such as tracheal lesions or COPD. Q17. Why is it important to recognize the sound of wheezing? A17. Wheezing is a key symptom of asthma, and recognizing it can help identify the condition quickly during multimedia or clinical scenarios. Q18. What do pulmonary function tests, PFTs, show in asthma? A18. A decrease in FEV1, forced expiratory volume in 1 second, a decrease in FVC, forced vital capacity, and a decreased ratio of FEV1-FVC. Q19. What happens to FEV1 after using albuterol? A19. FEV1 increases by more than 12% and 200 mmol after using albuterol, a short-acting bronchodilator. This shows the airway obstruction is reversible. Q20. What happens to FEV1 after using methacholine or histamine? A20. FEV1 decreases by more than 20% after exposure to methacholine or histamine. These substances provoke bronchoconstriction and are used for diagnosing asthma. Q21. What is DLCO and how is it affected in asthma? A21. DLCO, diffusion capacity of the lung for carbon monoxide, measures how well gases are exchanged in the lungs. It is increased in asthma due to greater blood flow and lung tissue function during exacerbations. Q22. Are PFT results always abnormal in asthma? A22. No, PFTs are normal in between asthma exacerbations, attacks. Q23. What is the function of acetylcholine and histamine in asthma? A23. Acetylcholine and histamine cause bronchoconstriction, tightening of airways, and increase bronchial secretions. Q24. What is methacholine and why is it used? A24. Methacholine is an artificial form of acetylcholine used in diagnostic tests to provoke airway narrowing and identify asthma. Q25. How can blood tests help in asthma diagnosis? A25. A complete blood count, CBC, may show an increased number of eosinophils, which are white blood cells involved in allergic reactions. Q26. What is the role of skin testing in asthma? A26. Skin testing helps identify specific allergens that cause bronchoconstriction, such as pollen or pet dander. Q27. What does an increased IgE level indicate in asthma? A27. It suggests that asthma may have an allergic cause. IgE levels can guide treatment with medications like omalizumab, which targets IgE. Q28. How is asthma treatment structured? A28. Treatment follows a stepwise approach, adding medications progressively if symptoms are not controlled. Q29. What is the first treatment for asthma? A29. Start with a short-acting beta agonist, SABA, which provides quick relief by relaxing airway muscles. Q30. What are examples of SABA medications? A30. Albuterol, perbuterol, and levolbuterol. Q31. What is added to SABA if more control is needed? A31. A low-dose inhaled corticosteroid, ICS, is added as a long-term control agent. Q32. What are examples of ICS medications? A32. Beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and triamcinolone. Q33. What are the side effects of inhaled corticosteroids? A33. Dysphonia, difficulty speaking or hoarseness, and oral candidiasis, a fungal infection in the mouth. Q34. What are alternative long-term control agents? A34. Cromolyn and nedocromil, theophylline, and leukotriene modifiers. Q35. Are there risks with leukotriene modifiers? A35. Yes, zafilukast can cause liver damage, hepatotoxicity, and has been associated with Churg-Strauss syndrome, a rare condition causing inflammation in blood vessels. Q36. What is added in Step 3 of asthma treatment? A36. A long-acting beta agonist, LABA, is added to SABA and ICS. Alternatively, the ICS dose may be increased. Q37. What are examples of LABA medications? A37. Salmeterol and formoterol. Q38. Can LABA be used alone? A38. No, LABA should never be used alone or as the first treatment. It must be combined with ICS to avoid risks. Q39. What happens in Step 4 of asthma treatment? A39. The ICS dose is increased to the maximum, and tiotropium, an antimuscarinic agent, is added to SABA, LABA, and ICS. Q40. When is omalizumab added? A40. Omalizumab is added if the patient has elevated IgE levels, suggesting an allergic component to asthma. Q41. What is the final step if asthma remains uncontrolled? A41. Oral corticosteroids like prednisone are used when all other therapies are insufficient. Q42. Why are systemic corticosteroids considered a last resort for asthma treatment? A42. They have severe adverse effects which can harm the body in multiple ways. Q43. What are the adverse effects of systemic corticosteroids like prednisone? A43. Osteoporosis, cataracts, adrenal suppression, fat redistribution, metabolic issues and skin issues. Q44. Are high-dose inhaled steroids as harmful as systemic steroids? A44. No. High-dose inhaled steroids rarely cause the severe side effects seen with systemic steroids like prednisone. Q45. What agents can be used to avoid systemic steroid therapy? A45. Monoclonal antibodies, bronchial thermoplasty, and anticholinergics. Q46. What vaccines are recommended for asthma patients? A46. Influenza vaccine and pneumococcal vaccine. Q47. How is respiratory rate used to assess asthma severity? A47. A normal respiratory rate is 10 to 16 breaths per minute, and a respiratory rate of 34 breaths per minute suggests severe shortness of breath. Q48. Why might accessory muscle use be hard to assess? A48. It is subjective and depends on the observer's experience. Q49. What does pulse oximetry measure in asthma patients? A49. It measures oxygen levels in the blood and may not detect hypoxia, low oxygen, until the patient is near respiratory failure. Q50. Can pulmonary function tests, PFTs, be done during an asthma attack? A50. No, PFTs cannot be done during acute shortness of breath. Q51. What tests quantify asthma exacerbation severity? A51. Peak expiratory flow, PEF, and arterial blood gas, ABG. Q52. What is the significance of PEF in asthma? A52. It estimates the forced vital capacity, FVC, and the patient's usual PEF, when stable, is compared to their PEF during an attack to assess severity. Q53. Why might asthma predispose to pneumothorax? A53. Asthma increases the risk of pneumothorax, collapsed lung, due to increased airway pressure during an attack. Q54. What is the best initial therapy for acute asthma exacerbation? A54. Oxygen, albuterol, a short-acting beta agonist, and corticosteroids. Q55. What is the role of ipratropium in asthma treatment? A55. It is an anticholinergic that dilates the airways and reduces mucus production, but it works slower than albuterol. Q56. Is epinephrine used in asthma treatment? A56. Epinephrine injections are rarely used because they are not more effective than albuterol and have more side effects. Q57. When is magnesium used in asthma? A57. Magnesium is used in severe exacerbations not responding to multiple rounds of albuterol. It helps with bronchodilation, but is less effective than albuterol, ipratropium, or steroids. Q58. Which medications are not effective for acute asthma exacerbations? A58. Theophylline, cromolyn, and nedocromil, leukotriene modifiers, omalizumab, and labas. Q59. What should be done if oxygen, albuterol, and steroids fail? A59. If the patient develops respiratory acidosis or continues to deteriorate, they may require endotracheal intubation and intensive care unit, ICU, admission for mechanical ventilation. Q60. What is COPD, chronic obstructive pulmonary disease? A60. COPD is a condition where lung damage causes difficulty breathing due to a loss of the lung's elastic recoil, which normally helps with exhaling air. Q61. What role do elastin fibers play in the lungs? A61. Elastin fibers allow the lungs to passively exhale air by recoiling. In COPD, these fibers are destroyed, making it hard to breathe out. Q62. How does COPD affect pulmonary function tests, PFTs? A62. FEV1, forced expiratory volume in 1 second, and FVC, forced vital capacity, are decreased, while total lung capacity, TLC, is increased due to trapped air. Q63. Is COPD the same as asthma? A63. No. Both are obstructive lung diseases, but COPD is caused by lung destruction and is not always associated with airway reactivity like asthma. Q64. What is the most likely cause of COPD in a young, non-smoking patient? A64. Alpha-1 antitrypsin deficiency, a genetic disorder, is the most likely cause. Q65. What is the most common cause of COPD? A65. Tobacco smoking, which destroys elastin fibers in the lungs. Q66. What are the main symptoms of COPD? A66. Shortness of breath, exacerbations with increased coughing and sputum, a barrel chest and muscle wasting and weight loss, cachexia. Q67. What does a chest X-ray show in COPD? A67. Increased anterior-posterior, AP diameter, air trapping, and flattened diaphragms. Q68. What does PFT show in COPD? A68. Decreased FEV1 and FVC, FEV1-FVC ratio below 70%, increased TLC and decreased DLCO, only in emphysema, not chronic bronchitis. Q69. How do bronchodilators affect COPD? A69. Responses vary from no improvement to full reversibility, defined as a greater than 12% or 200 ml increase in FEV1 after using bronchodilators. Q70. What does plethysmography show in COPD? A70. It shows increased residual volume, meaning more air is left in the lungs after exhaling. Q71. What happens to ABG values during a COPD exacerbation? A71. Increased PCO2, hypoxia, respiratory acidosis, and elevated bicarbonate levels. Q72. What does CBC show in COPD? A72. Increased hematocrit due to chronic hypoxia. Q73. What changes can be seen on an EKG in COPD? A73. Right atrial hypertrophy, right ventricular hypertrophy, and atrial fibrillation or multifocal atrial tachycardia. Q74. What does echocardiography show in COPD? A74. Right atrial hypertrophy, right ventricular hypertrophy, and pulmonary hypertension. Q75. When is oxygen therapy indicated for COPD? A75. When PO2 is less than 55 mm/Hg or oxygen saturation is NAHARNS 88%, or in cases of pulmonary hypertension, high hematocrit or heart problems when PO2 is less than 60 mmHg or saturation HARS 90%. Q76. What is the most important lifestyle change to improve mortality in COPD? A76. Smoking cessation. Quitting smoking prevents further lung damage and slows disease progression. Q77. How does oxygen therapy improve survival in COPD? A77. Oxygen therapy helps patients with PO2, USC 55 mmHg or oxygen saturation, 88%, reducing strain on the heart and lungs. Q78. Why are influenza and pneumococcal vaccinations important for COPD patients? A78. They prevent infections that can worsen COPD symptoms and cause life-threatening complications like pneumonia. Q79. What are short-acting beta agonists, SABAs, and how do they help in COPD? A79. SABAs, such as albuterol, relax the muscles around airways, providing quick relief from shortness of breath. Q80. What are anticholinergic agents and why are they effective in COPD? A80. Anticholinergics like tiotropium, ipratropium, aclidinium, umeclidinium, and glycopyrrolate block signals that cause airway constriction and reduce mucus production, making breathing easier. Q81. How do inhaled steroids help in COPD? A81. Inhaled steroids reduce airway inflammation, but are generally added only when symptoms persist despite other treatments. Q82. What are long-acting beta agonists, LABAs, and how are they used? A82. LABAs, such as salmeterol, formoterol, and olodaterol, are used daily to keep airways open for longer periods, improving breathing. Q83. How does pulmonary rehabilitation improve symptoms? A83. It combines exercise, education, and support to strengthen lung function and improve quality of life. Q84. What is the treatment strategy for asthma versus COPD not controlled with albuterol? A84. For asthma, add an inhaled steroid to control inflammation. For COPD, add an anticholinergic first, then an inhaled steroid if needed. Q85. What is the role of theophylline in COPD treatment? A85. Theophylline relaxes airway muscles and can help when standard treatments fail, but its effects are limited and it has side effects. Q86. What is roflumilast and how does it help? A86. Roflumilast reduces inflammation and may lower the frequency of COPD exacerbations. Q87. What is lung volume reduction surgery and when is it considered? A87. This surgery removes damaged lung tissue to improve breathing. It's used for severe cases when medical therapy isn't enough. Q88. When is a lung transplant considered in COPD? A88. If all treatments fail to manage symptoms and improve quality of life, a lung transplant may be necessary. Q89. What treatments do not benefit COPD patients? A89. Cromolyn, leukotriene modifiers, e.g. montelukast, and N-acetylcysteine, NAC. Q90. Why is inhaled steroid monotherapy incorrect in COPD? A90. Inhaled steroids should always be combined with other medications like LABAs or anticholinergics. Steroids alone do not improve outcomes. Q91. Why is intravenous IV aminophylline not used for acute exacerbations? A91. It's less effective than IV steroids or albuterol and has more side effects, so it's not recommended. Q92. Why is long-term maintenance antibiotic use incorrect for COPD? A92. Antibiotics are only used during infections, not for routine management. Q93. Why is spirometry not used for screening asymptomatic individuals even with a smoking history? A93. Spirometry is only done if there are symptoms like shortness of breath. Screening asymptomatic people doesn't provide useful results. Q94. Why is NAC ineffective as a treatment for COPD? A94. NAC does not improve lung function and may cause irritation or worsen symptoms. Q95. Why is terbutaline not recommended for COPD? A95. Terbutaline is a beta-2 agonist like albuterol, but offers no extra benefit and has no specific role in COPD. Q96. If asked which medication delays COPD progression, what is the correct answer? A96. Nothing. No medication can stop the disease from progressing. Treatments only manage symptoms or improve survival. Q97. When should theophylline or roflumilast be chosen in COPD management? A97. Use them if the patient is already on a SABA, a LABA, a LAMA, and inhaled steroids, but still has severe symptoms, and the goal is to avoid using long-term oral steroids. Q98. What is an acute exacerbation of chronic bronchitis, AECB? A98. It is a sudden worsening of chronic bronchitis symptoms like increased shortness of breath, cough, and mucus production, often due to infections or irritants. Q99. Which anticholinergic agent is used in acute exacerbations of COPD? A99. Ipratropium is the only anticholinergic agent recommended for acute use because it relaxes airway muscles and reduces mucus production. Q100. Why are antibiotics used in AECB? A100. Infections are the most common cause of AECB. Antibiotics help treat or prevent bacterial infections. Q101. Which infections are antibiotics aimed at treating in AECB? A101. Antibiotics target Streptococcus pneumonia, Haemophilus influenzae, and Moraxella catarrhalis. Q102. What are the most effective antibiotics for AECB? A102. Macrolides, cephalosporins, amoxicillin clavulanic acid, and quinolones. Q103. What are second-line antibiotics for AECB? A103. Doxycycline and trimethoprim sulfamethoxazole, TMP-SMX. Q104. How often are viruses responsible for AECB? A104. Viruses cause 20% to 50% of AECB episodes, but antibiotics are still used because bacterial infections are common. Q105. Why is oxygen therapy used in COPD? A105. Oxygen therapy helps reduce mortality by improving oxygen levels in the blood and preventing complications like heart strain. Q106. What are the criteria for starting oxygen therapy in COPD? A106. PO2 below 55 mmHg or oxygen saturation 88%, or PO2 below 60 mmHg or oxygen saturation 90% if there are signs of right-sided heart disease or high hematocrit. Q107. Is the concept of eliminating hypoxic drive accurate? A107. No, it is not correct. Patients with COPD must receive oxygen if hypoxic, but excessive oxygen, e.g. 100% high-flow oxygen, should be avoided. Use just enough to keep saturation above 90%. Q108. What happens if too much oxygen is given to a COPD patient? A108. Giving excessive oxygen can worsen CO2 retention, hypercapnia, in some COPD patients, so oxygen should be carefully titrated. Q109. What are LABAs and how do they work? A109. LABAs, long-acting beta agonists, relax the muscles around airways, keeping them open for extended periods. Q110. What are LAMAs and how do they work? A110. LAMAs, long-acting muscarinic antagonists, block signals that tighten airway muscles, reducing mucus and improving breathing. Q111. Can LABAs be used alone in COPD treatment? A111. No, LABAs should always be combined with inhaled steroids to prevent complications and improve outcomes. Q112. Which antimuscarinic agent is used for acute exacerbations of asthma and COPD? A112. Ipratropium is the preferred antimuscarinic for acute exacerbations. Q113. What is lung volume reduction surgery and who benefits from it? A113. This surgery removes damaged lung areas, bully, to improve lung function. It helps some patients with severe COPD and significant lung damage. Q114. What is bronchiectasis? A114. Bronchiectasis is a condition where the large airways, bronchi, in the lungs become permanently widened and damaged. This abnormality cannot be reversed or cured. Q115. Why is bronchiectasis less common today? A115. It is less common because we now have better treatments for lung infections, which were the main cause of this condition in the past. Q116. What is the most common cause of bronchiectasis? A116. The most common cause is cystic fibrosis, which accounts for about half of all cases. Q117. What other factors can cause bronchiectasis? A117. Infections, immune system problems, obstructions, allergic bronchopulmonary aspergillosis, ABPA, and collagen vascular diseases. Cas118. What are the main symptoms of bronchiectasis? A118. Chronic cough, excessive mucus production, recurrent respiratory infections, and hemoptysis, coughing up blood. Q119. How does bronchiectasis differ from COPD in symptoms? A119. Bronchiectasis typically involves more daily cough and sputum production compared to the intermittent exacerbations seen in COPD. Q120. What does a chest X-ray show in bronchiectasis? A120. Chest X-rays may show dilated, fluid-filled airways, but a normal X-ray does not rule out the condition. Q121. What is the most definitive test for diagnosing bronchiectasis? A121. High-resolution computed tomography, HRCT, of the chest is the gold standard for diagnosing bronchiectasis. Q122. What does HRCT show in bronchiectasis? A122. HRCT demonstrates the dilated, fluid-filled airways that are the hallmark of bronchiectasis. Q123. How do pulmonary function tests, PFTs, appear in bronchiectasis? A123. PFTs often show an obstructive pattern, but the severity can vary depending on the extent of lung damage. Q124. What is the role of sputum cultures in bronchiectasis? A124. Sputum cultures help identify the specific bacteria causing infections, guiding antibiotic treatment. Q125. What are the most common bacteria found in bronchiectasis sputum? A125. Pseudomonas aeruginosa, Haemophilus influenzae, Staphylococcus aureus, and Streptococcus pneumonia. Q126. How is bronchiectasis managed? A126. Treatment focuses on airway clearance, preventing and treating infections, and managing symptoms. Q127. What is the role of chest physiotherapy in bronchiectasis? A127. Chest physiotherapy, including postural drainage and airway clearance techniques, helps remove excessive mucus. Q128. What is the role of inhaled antibiotics in bronchiectasis? A128. Inhaled antibiotics like tobramycin or colistin can help suppress chronic bacterial infections in the lungs. Q129. When are oral antibiotics used in bronchiectasis? A129. Oral antibiotics are used to treat acute infectious exacerbations, often with broad-spectrum agents like amoxicillin clavulanate. Q130. What is the role of inhaled corticosteroids in bronchiectasis? A130. Inhaled corticosteroids may help reduce airway inflammation, but their role is less established than in asthma or COPD. Q131. When is long-term oxygen therapy indicated for bronchiectasis? 131. Oxygen therapy is indicated for bronchiectasis patients with resting hypoxemia, similar to the criteria for COPD. Q132. What is the role of surgery in bronchiectasis? A132. Surgery such as lobectomy or pneumonectomy may be considered for localized disease that does not respond to medical management. Q133. How does cystic fibrosis differ from other causes of bronchiectasis? A133. Cystic fibrosis is a genetic disorder that causes severe progressive lung damage leading to bronchiectasis, unlike other causes. Q134. What is the most common cause of death in cystic fibrosis? A134. Respiratory failure due to progressive lung disease is the most common cause of death in cystic fibrosis. Q135. How does the treatment of bronchiectasis due to cystic fibrosis differ? A135. Cystic fibrosis requires more aggressive airway clearance techniques, inhaled antibiotics, and often pancreatic enzyme replacement therapy. Q136. What is pulmonary hypertension? A136. Pulmonary hypertension is a condition where the blood pressure in the pulmonary arteries, which carry blood from the heart to the lungs, is abnormally high. Q137. What are the main causes of pulmonary hypertension? A137. The main causes are left-sided heart disease, lung diseases like COPD and interstitial lung disease, blood clots in the lungs, and idiopathic, unknown, causes. Q138. What are the common symptoms of pulmonary hypertension? A138. Shortness of breath, fatigue, chest pain, lightheadedness, and swelling in the legs. Q139. How does pulmonary hypertension differ from systemic hypertension? A139. Pulmonary hypertension affects the blood vessels in the lungs, while systemic hypertension affects the blood vessels in the body. Q140. What is the pathophysiology of pulmonary hypertension? A140. It involves vasoconstriction, vascular remodeling, and increased resistance in the pulmonary arteries, leading to right ventricular strain and failure. Q141. What does an echocardiogram show in pulmonary hypertension? A141. It can detect right ventricular hypertrophy and dilation, as well as estimate the pulmonary artery pressures. Q142. What is the gold standard test for diagnosing pulmonary hypertension? A142. Right heart catheterization, which directly measures the pressures in the pulmonary arteries. Q143. What are the treatment goals for pulmonary hypertension? A143. The goals are to improve symptoms, exercise capacity, and survival, as well as prevent or delay right ventricular failure. Q144. What are the main classes of medications used to treat pulmonary hypertension? A144. Vasodilators, e.g. sildenafil, tadalafil, riotigvat, prostacyclins, e.g. epoprostenol, treprostinil, and endothelin receptor antagonists, e.g. bosentan, ambrisentan. Q145. When is oxygen therapy indicated for pulmonary hypertension? A145. Oxygen is used to treat hypoxemia and prevent further pulmonary vascular remodeling. Q146. What is the role of diuretics in pulmonary hypertension? A146. Diuretics help reduce fluid overload and right ventricular strain, but they must be used cautiously to avoid excessive volume depletion. Q147. When is lung transplantation considered for pulmonary hypertension? A147. Lung transplantation may be an option for patients with severe progressive pulmonary hypertension that is not responding to medical therapy. Q148. What is the prognosis for pulmonary hypertension? A148. The prognosis is generally poor, with a median survival of 2 to 3 years for idiopathic pulmonary hypertension without treatment. Q149. How does pulmonary hypertension affect the right ventricle? A149. The increased pressure in the pulmonary arteries leads to right ventricular hypertrophy and dilation, which can eventually cause right heart failure. Q150. What is the role of exercise in pulmonary hypertension? A150. Exercise training can improve exercise capacity and quality of life in some patients with pulmonary hypertension. Q151. What is the significance of syncope, fainting, in pulmonary hypertension? A151. Syncope is a poor prognostic sign in pulmonary hypertension, indicating advanced disease and increased risk of mortality. Q152. How does pulmonary hypertension differ from cor pulmonale? A152. Pulmonary hypertension is the cause, while cor pulmonale refers to the resulting right ventricular enlargement and dysfunction. Q153. What is the difference between primary and secondary pulmonary hypertension? A153. Primary pulmonary hypertension has no known cause, while secondary pulmonary hypertension is due to an underlying condition like COPD or heart disease. Q154. What is the role of calcium channel blockers in pulmonary hypertension? A154. Calcium channel blockers are used only in a small subset of patients with a positive vasoreactivity test, as they can worsen outcomes in most cases of pulmonary hypertension. Q155. What is interstitial lung disease, ILD? A155. Interstitial lung disease is a group of lung disorders that involve inflammation and scarring of the lung tissue between the air sacs, the interstitium. Q156. What are the main causes of interstitial lung disease? A156. Common causes include idiopathic pulmonary fibrosis, connective tissue diseases, environmental occupational exposures, and certain medications. Q157. What are the typical symptoms of interstitial lung disease? A157. Shortness of breath, dry cough, and crackles on lung exam are the most common symptoms. Q158. How does the chest X-ray appear in interstitial lung disease? A158. Chest X-rays often show a reticular, net-like, or reticular nodular pattern, but they may appear normal early in the disease. Q159. What is the role of high-resolution CT, HRCT, in diagnosing ILD? A159. HRCT is the best imaging modality for diagnosing and characterizing the specific type of interstitial lung disease. Q160. What findings on HRCT are characteristic of idiopathic pulmonary fibrosis? A160. HRCT typically shows a basal predominant peripheral reticular pattern with honeycombing. Q161. What is the role of pulmonary function tests, PFTs, in ILD? A161. PFTs often show a restrictive pattern with decreased lung volumes and diffusion capacity, DLCO. Q162. When is a lung biopsy needed in the evaluation of ILD? A162. A lung biopsy may be necessary if the diagnosis remains unclear after clinical, radiographic, and PFT evaluation. Q163. What is the treatment approach for idiopathic pulmonary fibrosis? A163. Treatment includes antifibrotic medications like pirfenidone and nintedanib, as well as oxygen therapy and lung transplantation for advanced disease. Q164. What is the role of corticosteroids in the treatment of ILD? A164. Corticosteroids are used cautiously, as they are not effective for all types of ILD and can have significant side effects. Q165. What is the prognosis for idiopathic pulmonary fibrosis? A165. Idiopathic pulmonary fibrosis has a poor prognosis, with a median survival of 3 to 5 years from the time of diagnosis. Q166. What is sarcoidosis, and how does it affect the lungs? A166. Sarcoidosis is a multisystem granulomatous disease that commonly involves the lungs, causing inflammation and fibrosis. Q167. What are the typical radiographic findings in pulmonary sarcoidosis? A167. Chest X-rays often show bilateral hilar lymphadenopathy and reticular nodular opacities. Q168. How do pulmonary function tests appear in sarcoidosis? A168. PFTs typically show a restrictive pattern with reduced lung volumes and diffusion capacity. Q169. What is the role of corticosteroids in the treatment of pulmonary sarcoidosis? A169. Corticosteroids are the mainstay of treatment for symptomatic or progressive pulmonary sarcoidosis. Q170. What is the prognosis for pulmonary sarcoidosis? A170. The prognosis is generally good, with many patients experiencing spontaneous remission. However, some develop progressive fibrosis with a poorer outcome. Q171. What is hypersensitivity pneumonitis and how does it differ from other ILDs? A171. Hypersensitivity pneumonitis is an inflammatory lung disease caused by an immune reaction to inhaled organic dusts or chemicals. It is often reversible if the offending exposure is eliminated. Q172. What are the typical symptoms of hypersensitivity pneumonitis? A172. Acute episodes involve fever, chills, cough and shortness of breath, while chronic cases have insidious onset of cough and dyspnea. Q173. What is the role of environmental history in diagnosing hypersensitivity pneumonitis? A173. Identifying the specific exposure that triggers the immune reaction is crucial for diagnosis and treatment. Q174. How do the radiographic findings in hypersensitivity pneumonitis differ from other ILDs? A174. Chest imaging often shows a more diffuse ground glass appearance rather than the reticular patterns seen in other ILDs. Q176. What is lung cancer? A176. Lung cancer is a type of cancer that starts in the lungs and can spread to other parts of the body. Q177. What are the main types of lung cancer? A177. The two main types are small cell lung cancer, SCLC, and non-small cell lung cancer, NSCLC, which includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Q178. What are the primary risk factors for lung cancer? A178. Smoking is the leading risk factor, accounting for 80 to 90% of lung cancer cases. Other risk factors include radon exposure, asbestos exposure, and family history. Q179. What are the common symptoms of lung cancer? A179. Cough, coughing up blood, chest pain, shortness of breath, wheezing, hoarseness, weight loss, and recurrent infections. Q180. How does lung cancer spread? A180. Lung cancer can spread locally to the chest wall, diaphragm, and mediastinal structures. It can also metastasize to distant organs like the brain, liver, and bones. Q181. What imaging tests are used to diagnose lung cancer? A181. Chest X-ray, CT scan, and PET scan are commonly used to detect and stage lung cancer. Q182. What is the role of biopsy in lung cancer diagnosis? A182. Biopsy, either via bronchoscopy, CT-guided, or surgical, is necessary to confirm the diagnosis and determine the specific type of lung cancer. Q183. How are non-small cell lung cancers staged? A183. NSCLC is staged using the TNM system, which considers the size and spread of the primary tumor, T, involvement of lymph nodes, N, and presence of distant metastases, M. Q184. What is the treatment for early-stage non-small cell lung cancer? A184. Surgery is the primary treatment for early-stage NSCLC, often combined with chemotherapy and/or radiation therapy. Q185. What is the role of chemotherapy in lung cancer? A185. Chemotherapy is used in various settings, including adjuvant therapy after surgery, concurrent with radiation, and for advanced or metastatic disease. Q186. What are the common chemotherapy regimens used for lung cancer? A186. Commonly used agents include platinum-based drugs, e.g. cisplatin, carboplatin, taxanes, e.g. paclitaxel, docetaxel, and others like gemcitabine and vinorelbine. Q187. What is the role of targeted therapy in lung cancer? A187. Targeted therapies like tyrosine kinase inhibitors, e.g. erlotinib, gefitinib, and monoclonal antibodies, e.g. bevacizumab, are used for certain genetic subtypes of NSCLC. Q188. What is the role of radiation therapy in lung cancer? A188. Radiation therapy is used in various settings, including definitive treatment for early-stage NSCLC, concurrent with chemotherapy, and for palliation of symptoms. Q189. How is small cell lung cancer, SCLC, typically treated? A189. SCLC is usually treated with a combination of chemotherapy and radiation therapy, as it is more aggressive and responds better to these modalities. Q190. What is the prognosis for lung cancer? A190. The prognosis for lung cancer varies greatly depending on the stage at diagnosis, with earlier stage disease having a much better 5-year survival rate compared to advanced metastatic disease. Q191. What is the role of smoking cessation in lung cancer? A191. Quitting smoking, even after a lung cancer diagnosis, can improve outcomes and reduce the risk of developing a second primary lung cancer. Q192. What is the significance of paraneoplastic syndromes in lung cancer? A192. Paraneoplastic syndromes such as hypercalcemia, SIADH, and Lambert-Eaton myasthenic syndrome can be the first sign of an underlying lung cancer. Q193. How does lung cancer differ in never smokers compared to smokers? A193. Lung cancer in never smokers is more likely to be adenocarcinoma and is associated with different genetic mutations such as EGFR and ALK. Q194. What is the role of screening for lung cancer? A194. Low-dose CT screening is recommended for high-risk individuals, such as heavy smokers, as it can detect lung cancer at an earlier